welcome everybody. I'm going to exit stage right.
Let's see, I think we have a series of slides, and so if I'm correct, Dr. Sharda is going to go first.
Hello. Thank you all for having me today. Before we get started, I have to give kudos to some amazing Duke undergraduate students who have used art to showcase their experience with older adults and the journeys they've been witness to. And there is a lovely article in the Journal for the American Geriatric Society written by Drs. Wong and Dr. Pinheiro that I'd love to share if anybody's interested. So today we will start the conversation by thinking about what is dementia and what do we do about it? What are the risk factors? How do we make the diagnosis? And what are the medical management options? First, I'll ask you to reflect with me. In 1 or 2 words, think about your greatest fear when you think about dementia. In 1 or 2 words, what is your greatest hope when you think about dementia? This is Big Nana and my son 5 years ago. Big Nana is the term American-born Indians affectionately call great-grandfather, at least in my family. Big Nana was somebody who was very proud, hardworking, family-oriented, and the last 10 years of his life was overshadowed by dementia. In his last year, he couldn't walk and required total care. He had a team of 4 children and his wife who tirelessly worked to keep him at home until his final days. I asked his daughter what her biggest fear was, and she had a fear of a similar fate for herself. I asked her when she first noticed changes in him, or what those changes were, and she noticed that he started to get lost when driving. I asked his wife the same question. She noticed that he forgot to pack his suit when they traveled for a family wedding. She shared with me her regrets for not stepping in and speaking out sooner when she noticed very subtle changes. His wife and daughter both shared, though, their immense hope for the future of dementia treatment. They also shared how important it was for them to learn about the disease and for them to understand disease progression with regards to how it impacted their approach with him and their own expectations. I will say that we all fondly remember his smile when he engaged with any of his great-grandchildren. So often in clinic, I will hear, "My memory's pretty good for my age. Isn't that normal?" So let's talk about what is normal. A decline in brain weight and size, perhaps slowed processing speeds and verbal abilities, and last, but certainly not least, an accumulation of experience and wisdom. So to illustrate that further, let's take a look at this graph. So on the x-axis, you will see age, and on the y-axis is personal cognitive ability. The dashed horizontal line is the threshold under which you are unable to perform activities of daily living, bathing, dressing, feeding, grooming, independently. So as you can see, with normal aging and even mild cognitive impairment, you're above that threshold. So what is dementia, otherwise termed major neurocognitive disorder? It's a syndrome that is not reversible. It's memory impairment beyond what is expected for normal age. You'll see deficits in domains of cognition, for example, the ability to reason, or errors in judgment. It interferes with social, functional, or even occupational performance. We talk about dementia as this umbrella term, Most commonly, we diagnose Alzheimer's dementia. We also see patients who have vascular dementia, Lewy body dementia, frontotemporal dementia, and other diseases such as Huntington's disease. Not uncommonly, the picture might be mixed. The Alzheimer's Association published that more than 6 million Americans are living with Alzheimer's. By the year 2050, this number is projected to be nearly 13 million. The cost is astronomical, $345 billion, half of which are Medicare dollars, and a quarter just in personal out-of-pocket costs, for example, caregiving. 7 in 10 Americans would want to know early if they have Alzheimer's disease, if it could allow for earlier treatment. They also published data to suggest that the stage at which US adults would want to know is early, so specifically mild cognitive impairment and mild Alzheimer's disease. So let's turn to risk factors. Non-modifiable risk factors including age, education, genetics, specific diseases such as Parkinson's. The lifetime risk for Alzheimer's at age 45 is 1 in 5 in women and 1 in 10 in men. Modifiable risk factors include alcohol, smoking, isolation, depression, high-risk medications, high blood pressure, high sugars, a sedentary lifestyle. All things that we aim to intervene on early to optimize our risk profile to decrease the risk of developing cognitive impairment. So how do we make the diagnosis? The crux is truly in the clinical history, supported by a focused physical exam, a neuropsychiatric evaluation, and perhaps laboratory and imaging data to really rule out any reversible etiologies. So what matters? What are we asking for when we see somebody? What is the time frame? Is this something that's occurred over months to years or days to weeks? Have you noticed any changes in independence? Are we missing bills, getting lost, even remembering to eat? Any judgment and safety concerns? Are we leaving the stove on? Have we noticed a lot of falling? Vision impairment, hearing impairment, these all increase the risk of cognitive impairment. And finally, are you noticing a change in behavior, mood, or personality? We talked about screening tests, which could be as simple as a clock draw and as extensive as hours of questionnaires. I will say that the clock draw is a fantastic start, and I haven't been able to think of another alternative, so I'm hopeful this stays part of elementary school curriculum. So turning to pharmacological management, what are we trying to treat? Dementia-related symptoms can be a talk in and of itself. We like to think about depression, anxiety, insomnia, pain, adjustment to life stressors, a new medication and subsequent side effects. But again, these all have management pathways of their own. So let's turn to FDA-approved treatment for Alzheimer's disease. For several years, acetylcholinesterase inhibitors and NMDA receptor antagonists have been available. These are medications that impact the neurotransmitters in the brain. Mild to moderate dementia is where we'll usually employ acetylcholinesterase inhibitors, and as the disease progresses to moderate to severe, we might employ NMDA receptor antagonists. These two medications are often in pill form, but depending on the drug, can be available in a liquid formulation or a patch. They each come with some side effects. Additionally, you might have heard about these monoclonal antibodies, lecanemab, aducanumab. This is indicated for mild cognitive impairment or mild dementia. There are some pretty rigorous protocols for when this medication is used, and it also has some serious side effects. I will say that none of these drugs have been shown to cure or reverse Alzheimer's, but rather prolong the duration of maintaining your functional status. Particularly during trying those oral medications, it's important to talk to your provider about setting goals. How are we going to monitor benefit, or more importantly, how are we going to monitor harm? And so thinking about a trial period of about 3 months and thinking about reasons to discontinue. Are there side effects? How is the pill burden or the cost impacting the patient or family? And as dementia becomes very advanced, there's limited benefit as well. A quick discussion on antipsychotics. So these medications are off-label in dementia, but we will reach for them occasionally to manage neuropsychiatric symptoms. There's little evidence for long-term use. They can be helpful to manage acute aggression or agitation, most often in those with hallucinations. And important to note that they carry a black box warning of increased mortality when used for this indication. Again, worth that risk-benefit conversation with your provider. And finally, there are other products that have limited evidence with regards to how they impact dementia